Today's webinar is dedicated to radiology reporting in the age of personalized medicine. And the outstanding speaker we have today is Professor C Kahn. Professor C Kahn is Vice Chair of Radiology at the Pennsylvania University. Is the chair of the Structural Reporting Subcommittee of the Radiology Informatics Committee of the RSNA. Is an outstanding expert in this topic, and so it's my pleasure to give him all the right as presenter for this webinar, and we look forward to your questions at the end of this speech. I will give the right to all the people all the attendees that will ask for questions, the right to speak. So please, Professor Kahn, you are welcome.
Well, thank you very much, Professor Neri, and my thanks to you and to the European Society of Medical Imaging Informatics for the opportunity to present today. So, as Emanuele indicated, the title for my presentation is Radiology Reporting in the Age of Precision Medicine. And what I'd like to do today is to describe for you some of the new thinking about how we approach medicine and our role in radiology and the role that our central activity of generating radiology reports and what that has to do with the future of our profession. So just to give you a little bit of background, thinking back about 10 years, looking at the cost of sequencing a human genome has gone from $22 million per person per genome to now almost less than $1,000 US for the same information. In the same time, the time to sequence a genome has dropped from 2 years to less than 1 day. And along with that, the number of people who carry smartphones and who have resources available to access information and for information about them to be gathered and coordinated centrally has grown remarkably. Back in 2004, less than 2% of the US population, about 1 million people, had smartphones. Today, it's in excess of 160 million. And in the US, the number of organizations where health providers use electronic records has gone from about 1/4 to more than 90%. In that same time, the computing power that's available to us has grown 16-fold. The problem with all of this, and clearly we want to be able to apply this fantastic computing power in healthcare, but there are some central problems to it. And here you see a list of diseases, depression, asthma, diabetes, arthritis, Alzheimer's disease, and cancer, for whom even our best line treatments offer really not complete treatment. And, I think a lot of us used to think that of these diseases as one thing, but in fact, that's really not correct. And it would be the same as treating cancer as if that were one monolithic disease for which we were going to develop a treatment. And we know that's not true. And increasingly, we know that lung cancer isn't one disease. And we now begin to realize that even small cell lung cancer is not one disease. So part of the challenge in what we're doing is to be able to direct the information that we gather in radiology and link that with efforts to build on the work that's being done to deliver precision or personalized medicine for each patient based on their profiles. So here's kind of a diagram that shows really where people are thinking this is headed. In previous times, we really looked at patients' symptoms, and based on that, used treatments that we could, based on intuition or what information we had available to us. We know today that we seek patterns in that information and use evidence-based medicine as an approach to deliver care. But really what we want to be able to do is to target our therapies to really use a variety of very precise treatment algorithms, treatment processes that can identify, isolate the exact variety of the disease, the allelic variants in that disease that allow various chemotherapeutic agents and other agents to treat the disease, and to do so in a way that involves less toxicity, less risk to the patient, and more chance of success. And you see some of the things here that are pointed out: personal molecular fingerprints, looking at genomic and epigenomic data, and combining that with big data analytics. Big data is kind of a sexy term that people throw around, talking about not only the amount of data that's collected, but the velocity of data, how fast it comes in, and the variety of different types of data, combining that with reference databases that contain rules, algorithms of how to process that information, using those mobile communication technologies, and then coming up with precise strategies for prevention, diagnosis, and treatment of disease. So there was a report that was published a couple years ago by the U.S. National Research Council called Toward Precision Medicine, and the subtitle, which may be a little difficult to read there, Building a Knowledge Network for Biomedical Research and a New Taxonomy of Disease. And it seems kind of strange in a way, because that when we talk about this idea of precision medicine, and here they are talking about a new taxonomy, a new nomenclature, a new way of calling diseases. But there's a reason for that. And here's what to me is really kind of the key figure in that report. And so you see, they have this idea of a knowledge network, and these little things here within it are too small to read, but it says exposome, signs and symptoms, genome, epigenome, microbiome, other types of patient data, and individual patients. And the idea is to have an information commons, a way that information about all of these different aspects of individual patients can be stored, cataloged, discovered, and shared in a way that's interoperable, that makes it easy to use. And from that, one defines a taxonomy. Now, what is this taxonomy again? The idea is that you are identifying a specific type of the disease that you can then treat effectively. So again, it's not only a lung cancer, but it's a lung cancer with an ALK mutation that you know is going to be susceptible to particular care of chemotherapeutic agents. And so it's that taxonomy then accurately diagnose and treat in the clinical setting to measure health outcomes. But to me, this little green box here is really the key feature of the whole study, of the whole. The notion is that increasingly there isn't money to do big clinical trials. And in fact, to do clinical trials of all the different drugs coming along, all the different drugs that we seek to repurpose, would be really very challenging. And we know for a fact that only 2% of patients who are eligible to be enrolled in cancer clinical trials are actually enrolled. So how do we learn from these patients? Well, part of that is to actually learn from observational studies, from studies of patients in the routine course of receiving clinical care. And that's a particular opportunity that we have in radiology. So why is this the right one to do it? Because we have the technologies to rapidly and economically sequence the human genome. We have improved technologies for biomedical analysis, for the ability to analyze large volumes of data, and we have the tools that can analyze large data sets effectively. Jim Thrall, who is the former chair of the Board of Chancellors of the American College of Radiology and past radiologist in chief at Massachusetts General Hospital, part of the Harvard system, gave the Morton lecture a year ago, in which he talked about imaging in the age of precision medicine. And from his talk, a couple of key things, and you can find an article from that address that's in the Journal of the American College of Radiology, that image findings taken together represent the imaging phenotype of a disease or condition. Radiogenomics is the study of the relationship between patient genotype and imaging phenotype. That imaging, as many of us realize, is often the best way to provide surveillance for clinical occurrence, location, extent, and severity of diseases linked to gene mutations. And the results of imaging studies are often superior to other methods in establishing disease prognosis. And in fact, in most clinical care situations, it's imaging that we use to maintain the care of the patient. So one of the things going forward is there are a variety of a variety of approaches to link the genome with imaging findings, and in particular, there's been really fabulous work that's been done in a variety of areas where specific features of diseases, and an example is glioblastoma, looking at the margin and percentage of, and looking at the patterns of edema that surround it, looking at the particular imaging characteristics, has been shown to actually be associated with specific genes that are upregulated and with gene networks that are involved in proliferation and tumor aggressiveness. What does that mean? It means that the data that comes from the imaging findings can be used to determine prognosis of disease and actually can be linked to specific genes and gene expression profiles to determine the best treatments. The problem is, where are we today? And in fact, for most of us, our reports are a string of letters and spaces, really. It's the report information that we provide and the images that we take as part of our imaging studies. You know, we provide a set of pixels and a set of characters that's the narrative of the report, but rather lacking in meaning and things that can be used going forward. So one of the challenges we have, and the example that I pull up is one from a CT report dictated by a colleague, where I take out the paragraph separators and just run all the things together, and it just looks like a horrible piece of text. But really the key piece of information that one wants to get from that is the size of one particular lesion, so that one could graphically plot that information and use that information in clinical decision making. And what we have today really doesn't allow us to do that. And what we want to do is to be able to build in the technologies that will get us there. So part of the challenge for us who've been working at this notion of structured reporting is being able to capture the location and the size information in a way that those values can be extracted easily from the report and used for analysis and decision making. And as well, the other information in the report we want to be able to capture and link to controlled vocabularies such as RADLEX to improve the understanding and retrieval of report content. So with this in mind, and for a variety of other reasons, the RSNA started this effort to develop and further the technologies for radiology reporting and created a report template library, which was begun and the first version of which was delivered at the 2008 RSNA annual meeting with goals of jump-starting the adoption of structured reporting, to improve the quality of radiology reports, and to foster the development of systems that could help radiologists do a better job of producing the reports. And that effort went on in collaboration with a variety of subspecialty organizations. And I think many of you are familiar with the site that's been developed. It's at radreport.org, RADREPORT, radreport.org. And that website has broken out by various specialties, such as organ system areas and modalities. The more than 200 reporting templates that have been developed in the English language, plus a variety of templates that have been either translated from English or created in several other languages. And currently, the site has in excess of 250 report templates and has seen more than 2.7 views and downloads of that information in the last 4 years. We didn't start counting until the hits on the website until about 2012. But since then, the number of downloads to that site has continued to grow. Among the languages that are on the site, obviously the great majority of them are in English. We have a variety in Turkish and Chinese, and growing numbers of reports in some other languages as well. This library, that main one, we kind of have broken off and called the Select Template Library, and that consists of curated content that has been vetted and edited by experts, and the report elements, as I like to say, under the hood, sort of out of sight of the radiologist, but there within the template, that information has been coded with RADLEX terms so that those pieces of information can be digested more readily by automated systems. And some of you may have seen the diagram that I present that shows a reporting template for bone age. That's one version of it in Turkish and one version of it in Chinese. And yet the two templates, in effect, are interchangeable because the underlying content is the same, and both templates have the same RADLEX codes attached to them. So the impression stands out. Things that are flagged as normal carry the same code. So even though the surface language is different, the meaning is the same, and it allows that information to be interoperable. Along with that, we've created a portion of the RAD report site that we call the Open Template Library. And here, the idea is that anyone with RSNA or ESR member credentials can add to that site. Now, both sites, the Select site and the Open site, can be viewed or downloaded by anyone. But members of RSNA and ESR can add templates to the Open site, can rate. So the idea is that RSNA and ESR members can add templates, can rate templates that others have authored, and can post comments about those templates on the website. And there's links for people to log in. And once you log in with your ESR credentials or RSNA credentials, you can then get to the more active portions of the site. And so there's a link to that off the main site, or you can go to open.radreport.org. One of the technologies that lies behind this is called MRRT, the Management of Radiology Report Templates. And this is a profile developed by IHE Radiology. IHE is the Integrating the Healthcare Enterprise. It's an organization that doesn't develop standards per se, but takes standards that have been developed in other areas, like DICOM HL7, and develops what are called integration profiles that help people use those templates in their practice. Use those standards in their practice, because just having a standard doesn't necessarily mean it's going to get used. So the MRRT profile defines a specification for radiology reporting templates, and it does so in HTML, the language of the web. It incorporates Dublin Core, which is a technique for storing metadata, and it links to RADLEX terms. And so earlier this past year, we converted about 200 of the existing templates into the new standard, and that's the way they're published on the RAD Report website. And the advantage of this is because HTML is the web language, you can create radiology reporting templates that basically look like web forms. So they have areas to fill in text or numeric values, or having pick lists, for example, having a list of values that one can select from. So that's available on site, and that's a new standard that's been developed. And the vision is for radiology reports to be generated using a combination of measurements and annotations that might come in from your devices, like from ultrasound, so that a measurement would automatically flow into your radiology report. And then once that report is generated, it flows out to the electronic health record. And thanks to colleagues at Karos Health, K-A-R-O-S Health, they developed a template report editor called T-Rex, which is available online. And if you go through the openradreport.org site, you can get to that, and it has links to it. It's a free open source tool that allows one to create and edit radiology reporting templates in a very simple, direct, what's called WYSIWYG, what you see is what you get approach, where you can do it all online, and it makes it very easy. It's a wonderful tool that becomes part of the kit that we have available. So part of the effort of radiology reporting has been to capture information using these reporting templates as a way to provide more information in a way that's interoperable for radiologists and for us to store and use in a variety of forms, such as data registries. There have been a variety of other efforts. One that links radiology reporting to decision support tools, so that algorithms for follow-up recommendations for particular findings can be standardized and made uniform. I think many people here will be familiar with the Fleischner Society guidelines for lung nodules. What various organizations are doing now are building in rule engines that will allow one to basically walk through a decision tree based on the size and characteristics of a lung nodule, for example. And from that, it will add into your radiology report the appropriate recommendation for follow-up imaging or other action as necessary. So that's one effort that's in the works. There is a lot of interest in doing natural language processing of radiology reports to extract findings, to be able to understand the scope of the report more effectively. But in some ways, the difficulty with that will always be that if the information isn't provided in the report, that NLP won't be able to extract it. And in many ways, having a template, a structured template that one uses for the report, serves to help prompt the radiologist to provide the important pieces of information. The effort is linked with various other things, among others the ACR Head Injury Institute, efforts by the College of American Pathologists with their electronic cancer checklist, and with Cancer Care Ontario out of Ontario, the province of Ontario, Canada. They've developed a reporting template that is used across the province for reporting of all rectal cancer tumor staging MRI examinations. And so we've worked in collaboration with them. Another collaboration has been with the European Society of Radiology. The ESR, together with RSNA, have formed the Template Library Advisory Panel with joint membership from both organizations, and that serves as the editorial board for the library of reporting templates. So those are kind of the major initiatives that RSNA has undertaken. the report template library, the MRRT, Management of Radiology Report Template Standard, and building in within the DICOM standard, the connections to make that happen, the T-Rex template editor, and a new portion of this that I'd like to speak about, and I think will have tremendous impact on all of us going forward, is called common data elements. And the idea is that a common data element is a piece of data that is collected and stored uniformly across institutions and studies and defined in a data dictionary. So in a way, these are standardized questions with a standard set of allowed responses. And the way to think about this, maybe the best example is the BI-RADS assessment score in breast imaging. Every screening mammogram has to have a BI-RADS score from 0 through 5. You can't have 4.2. You can't leave it blank. You have a discrete set of answers that you can give, and it's going to be one from that list. So that's kind of a direction for much of this. And the idea is that a variety of, we've actually are putting together a test server, and we anticipate having another server that will be called radelement.org that will be in many ways parallel to radreport.org. For now, those who might be interested can go to radreport.org/element. And what you'll see there is in JSON, which is the JavaScript object notation, you'll see the list of the various data elements that have been defined. And if you go then type, for example, /element/1, you'll see the detailed information about that first one. So one of them, for example, is the Glasgow Coma scale, I-response scale, which is has allowed values of 1, 2, 3, 4, untestable, and unknown. And when it's used, you have to specify one of those. And what this repository does is it provides a human and machine readable format for the definitions of those reporting elements, so that anyone who would be choosing to use that within their radiology report, whether it's for a stroke CT or maybe it's for a trauma examination, that if they're going to include that information in their report, that this is the information that they use, so that it is standardized, so that the information is exactly the same across different applications. And that's the strong advantage of it. For things such as numerical values, like the size of a nodule, you can specify the units like millimeters. You can say it's going to be a value of between 0 and 999. And basically, you're defining the question that you're going to ask and the allowed responses that people can provide. So the reason for all of this is a movement from efficacy to effectiveness. When we look at technologies, and that includes diagnostic imaging and medical treatments, the efficacy is how well a technology works in a clinical trial or a laboratory study. It's really how well it works in best case scenarios. The effectiveness of a technology is how well it works in practice. And part of the goal that in order to meet precision medicine is to move from efficacy to effectiveness. We're not going to just be studying things in the laboratory and in a few high-power academic institutions. We really want to be able to engage the full range of medical practice to look at a better way to gather the information that we need in order to deliver healthcare. The traditional large-scale radiology clinical trials may be good for early technology and for measuring how well a certain diagnostic tool works, but the funding to conduct such trials is already significantly diminished and doesn't show any signs of coming back. And as well, often it's the case that by the time you conduct a big randomized controlled trial of a particular imaging modality, the technology has moved on, and the things that you studied are no longer relevant. So really, we want to change the focus of radiology trials to assess the impact of imaging on patient outcomes, not just on our ability to detect a finding. So really, radiology has a tremendous opportunity to participate in outcome studies in a value-driven healthcare environment, to use the data in a radiology report more effectively, to take structured reports and data mine the information that comes from those. And using that information in the aggregate will help us better understand the taxonomy of disease, and from there we'll be better able to address the care of our patients and improve healthcare outcomes. So with that, I thank you very much for your attention. Again, apologies that we seem to have a technology problem here and weren't able to share the slides with you, but I know we'll be able to, I'll ask Professor Neri, we'll make sure that my slide set here is available for people to view, and be happy to answer questions.
Yes. Thank you, Chuck, for your speech. Even without the slides, you were being perfect and very clear. And I apologize with all the attendees for this technical problem. The technical problem was caused by the delay in the screen sharing that we could not foresee. So we decided to go forward in the presentation instead of reloading the complete webinar, which was not convenient for everyone that had to access again. However, there are any questions for Professor Kahn? I would be happy to give you the right to speak if there are any of you that would like to make a direct questions. You can ask questions through the chat box or ask for for speak. I have questions from a comment. There are many comments, but the one from every comment is about the excellent lecture, even without the slides. So I know.
Thank you all for using your visual imagination to imagine the slides that I was showing. They were really good slides too.
No, they didn't. So they didn't completely, because meanwhile you was speaking, I convert the slides in PDF and I have sent the link to download the slides. So everyone could read the slides. And meanwhile he was speaking, I was trying to say the number, to suggest the number of the slides. So some of them could see the slides. So I hope. So if no one has questions, I have a question. Okay, there is one question from Sergei Morozov. He's asking, Charles, thank you. Do you have any data on structure reporting effect on an increase in radiology productivity? Very good question.
That's a wonderful question. So the question as to whether there is some information now that shows that structured reporting improves the completeness of reports. And makes them, we know that for the most part, that our referring colleagues like structured reports because it makes them easier for them to read and to find the information that is useful to them. It's very difficult to assess productivity. I haven't seen specific data on that yet, but there are very good signs that it helps with making reports more complete and more and preferred by the referring docs. I will say, in a teaching institution, one advantage of using a reporting template is that it makes it easier for me as when I review the report with our resident or fellow, to know that they've actually talked about the specific areas and also so that they haven't said it. I can tell very easily from looking at the report if it uses sort of the standardized words in each of the sections that they haven't, that they've looked at the right things, they've covered the right things in the report, and it actually makes it more productive for me to review it. But that's a really good question. I think we're still waiting to see some data on it. I will say, I think in general, the marketplace has spoken, because a lot of practices, and in particular, we have a community practice that's part of our group at Penn. In addition to the academic centers, we have a community radiology group, which is effectively a private practice. And so they're focused on productivity, and they are very interested in using reporting templates, and they think it helps them work more effectively and be more concise in their reporting.
Yeah. Okay. There is one question from Elmar Rotter from Freiburg. He's asking if there are any specific tools that you use to generate structured reports. Quite easy.
Well, there are a variety of them now. Most departments in the United States are using one of several commercial products that have their own approach for reporting templates, and then from those, people generate their reports. Part of the challenge that we've had in developing MRRT.
All attendees are muted and may unmute themselves by pressing *6.
Sorry, I got the message about muting and it derailed.
No, you can speak.
The challenge is that imagine back in the old days when every different manufacturer made a CT scanner, and the only way that you could view the information was on their CT viewing console in the days before DICOM. So the argument that we've tried to make to these vendors is that MRRT really is the platform that they need to move towards, so that we can have very simple tools for building the reporting templates, and then people can build tools for doing the reporting itself. But I think actually in the long haul, although there's some investment to be able to translate templates to and from MRRT into their own proprietary formats, that it'll be to their advantage, and it'll make the whole field more innovative and bring a lot of positive change.
Yeah. Okay. I see that there are many questions coming, so I try to give the right to speak to those that are asking questions. So I hope the microphone will work. So the first one is Dr. Hisham, Michael Hisham from Cairo. I try to give you the microphone. Okay, can you try to speak? No. So the question from him is, hi Charles, do you think structured reporting can reduce the creativity of radiologists describing what they see in their own way of wording?
So I have two answers to that. One is I certainly hope so, and two is no, it won't. So why do I say that? At some level, if the gallbladder is normal, let's just say the gallbladder is normal. We don't need to have people getting entirely creative and finding 15 different ways to say the same thing. On the other hand, when one designs a system for structured reporting, the structure should not become a straitjacket. The structure is not something that limits what people have to say, because there will always be cases in medicine that go beyond what we have thought about in the beginning of the process. So I don't think that it limits our creativity, but perhaps focuses it more usefully. And the hope is that rather than you and your colleagues and I, and we all have 15, 30, 50 different ways of all saying the same thing, that we all come down to one way of saying the same thing so that everyone understands it. We all agree what it means. And then we don't waste our time on misunderstandings. But where it's important for radiologists to be descriptive and for us to provide information in detail, there's nothing that should prevent us from doing so.
Okay, got it. Thanks, say Michael. There is a question from Jacob Visser from Rotterdam. He's asking, telling you that it was a good talk. And the question is, what is your vision about bringing structural reporting into clinical practice, as radiologists are reluctant to use a predefined environment? I think it's quite similar to the previous one.
Yeah, I will tell you that in a variety of settings, first off, it's often our referring physician colleagues who ask and demand that radiologists move in this direction, because in a lot of places we produce wonderful prose. We create these wonderful text reports, and the referring physicians won't read them. They don't want to read them. It's a horrible story here. We have one ear, nose, and throat surgeon who doesn't read radiology reports. He has his secretary go through the report with a yellow highlighter pen and only underline and highlight the pieces that the secretary thinks are important, and that's the only part of the report that the ENT doctor will read. Clearly this is not how we want radiologists and the information that we provide to be digested and used by our colleagues. I will tell you that in many practices, ours included, the use of reporting templates becomes part of the incentive program for the radiologists, that they actually have a financial incentive to use these templates. They can choose not to, but they have an incentive to take advantage of them. And as well, one way to do it in our practice that we are moving to is we set that up as a default, so that when you are reporting a study and you click the dictate button from the electronic health record, it opens the default template for that kind of examination in the reporting system. And that makes it much easier for people to use it. And in fact, I can tell you, I've had a number of colleagues, both here and at my previous institution, who were very resistant about using reporting templates initially, but then as they grew to use them, they found that it actually they found that it was more efficient, and they got accustomed to it and found it to be useful.
Okay, so we have another question from Duccio Buccicardi from Italy. He's a good friend of mine. And Duccio, are you able to speak on the microphone? Seems he's not able. So the question from Duccio is, that's a nice question. Older colleagues are afraid of structural reporting. They think structural reporting is a kind of cage. How could they be assured it's good?
I don't have all the answers to that. I don't know if it necessarily is our older colleagues, our more senior members of the profession, because there's some other folks who are not entirely comfortable with it too. But the fact of the matter is that as we go forward, more and more of the information that we need to provide to referring physicians and the pieces of information that are going to be critical are going to be not pieces of information that we want to have buried somewhere within a paragraph of text, but called out very plainly and easy for people to find within the report. And it's an evolution for all of us, I think. We're all working towards this. I think a lot of people realize it's the direction we have to go, but it's not necessarily something that we can get to right away. It's a process.
Yeah. Many thanks. There is another question from Professor Sommer, Wieland Sommer from Munich. I heard that structural reporting was introduced in ultrasound in the United States because it was required for payoff. Do you think that it will be similar and will become mandatory for CT and MRI in US?
It's the structured. I think one of the reasons that structured reporting is so common in ultrasound is that the kind of information that we gather in ultrasound is particularly suited for that. And in particular, we have technology at our institution that allows us to connect the measurements that come in on the ultrasound devices, and using the DICOM SR technology, that those measurements can flow directly into the radiology report. It makes us more efficient to do that. It's not required for payment per se to have a structured report in ultrasound. There are certain components that have to be in a report, and structured reporting or templates makes that easier. But they say there are three things that motivate people: making money, not losing money, and staying out of jail. So, in mammography in the United States, the MQSA, the Mammography Quality Standards Act, requires that radiologists provide the BI-RADS, provide certain elements of in a radiology report. And so, not surprisingly, radiologists provide those elements in the report. I don't think we're going to get to legislation on this. There may very well be economic motivation. And in particular, if you can imagine that, let's say on a rectal cancer MRI, that there are particular features that the surgeon needs to know in order to operate, or for the radiation oncologist to provide optimal therapy, we really should be providing that information. And so it doesn't have to be necessarily through the payment mechanism, but often just doing what our colleagues and need, and doing what's best for the patient. That should be our guide.
Well, yeah. And we have I think, would be the final question. A final question from a colleague from Verona, from Italy, Salvatore Sgroi, is asking, is the structural reporting, in your opinion, definitely going to become the future in radiology reporting? I think I know the question.
I think we see this as our future, as radiology becomes more quantitative, as we become closer to looking at specific imaging features and linking those with gene expression profiles and prognostic factors and therapies. The information that we generate from our reports will become more useful if we can put it in a form that allows it to be structured. Some of that we may be able to extract using natural language processing, but given the challenges and quite honestly the creativity and variety of human language, that poses a challenge. So I think in many ways, I don't know if it's absolutely the future, in some ironclad way, but I think it's something that we all want to move towards.